Assalamu alaikum. This is a practical session of physiology. I will try in this session to explain to you what is the spirometry and what is the clinical significance of applying spirometry in the clinical practice. The objective of this physiological lab session is first to explain that the spirometer is designed to measure lung volumes and to measure the flow rate, thus to say the volume per unit time. The second objective is to understand the purpose of performing the pulmonary function test. You need to know as medical students the normal values for the lung volumes and capacities, and we already took that in our theoretical lectures. So please refer back to the values that has been discussed and demonstrated in the theoretical lectures. Also, you need to know the effect of age, gender, body height, and race on lung volumes and capacities. And I already told you that when a person gets older, all volume values and capacities will be reduced. Regarding the gender, you know that the values in males usually are higher than that in females, and the same is applied for the body height. The greater the body height, the greater the values. Regarding the race, you know that some nations, usually the people are smaller in size than other nations. And I already put for you a video demonstrating how we can do the pulmonary function test. And please refer to that video. And lastly, we will try to understand from this session how we are going to apply some significant values like the forced vital capacity, the forced expiratory volume for the first second, and the percentage of the forced expiratory volume to the forced vital capacity, the peak expiratory flow rate, and the flow rate between, or the average between 25 and 75%. Also, we will try to apply these values to differentiate between different diseases, especially that for obstructive and restrictive pulmonary dysfunction. The pulmonary function test is not a single test. In fact, it's a group of tests. One of the most important tests within the pulmonary function test is the spirometry, meaning the measuring of breath. Spirometry is the most common of the pulmonary function tests, as I told you. This test is to measure the lung function and capacities. So it covers two things. First, it measures the amount or the volumes of the lung. And second, the spirometry enables us to measure the speed or the flow of air that can be inhaled and exhaled. Why do we do spirometry? Spirometry is useful in medicine in assessing breathing patterns that diagnose conditions such as asthma, pulmonary fibrosis, cystic fibrosis, chronic obstructive pulmonary diseases such as chronic bronchitis and emphysema. These are examples of the chronic obstructive pulmonary diseases. With spirometry, we can diagnose these cases because spirometry will show us that the forced expiratory volume for the first second divided by the forced vital capacity is less than 70%. I will demonstrate that to you soon. And when these values will be lowered, this simply indicates that both the forced expiratory volume in the first second and the forced vital capacities are reduced in chronic obstructive pulmonary diseases. We will discuss it soon in the other slides. Spirometry is useful for differential diagnosis, not just for the diagnosis. It helps us in medicine to differentiate between respiratory and cardiac diseases. Both respiratory and cardiac diseases causes dyspnea. So, spirometry will enable us to differentiate which is which. Also, spirometry will help us to differentiate between obstructive lung diseases and restrictive lung diseases. And we will learn that in obstructive lung diseases, the forced expiratory volume divided by the forced vital capacity usually is less than 80% or less than 70%, whereas this value will be normal or even higher than 80% in restrictive lung diseases. Restrictive lung diseases can be caused by pulmonary causes or extrapulmonary causes. Pulmonary causes means simply that the problem is within the lung, like fibrosis of the lung, whereas extrapulmonary causes something like obesity, diaphragmatic hernia, paralysis of the diaphragm, and many other diseases. We will come to that later. Spirometry is also useful to 1. Follow the natural history of disease in respiratory conditions. This means if we have a patient and this patient is complaining from a chronic respiratory disease and he has done before a test for the spirometry, we will do a new test for the spirometry and we will assess if the condition has been improved or the same or it has been worsened. Other usefulness for the spirometry is to assess impairment from occupational asthma. Many workers in many factories, they will come and complain from asthma due to the dust in these factories, and to assess if they have really an impairment or an asthma because of occupation, this simply will be decided by the spirometry. Spirometry is also useful to those at risk from pulmonary barotrauma while scuba diving. And scuba diving is simply an underwater diving with the use of scuba. And the scuba is a diving cylinder which contains compressed air. Not everybody is familiar with using such kind of apparatus, so to identify who is at risk, pulmonary spirometry is essential in such condition. Other usefulness for the spirometry is to conduct preoperative risk assessment before anesthesia or cardiothoracic surgery. You as a future doctor, you will compare the usefulness of certain medications. So if you are applying a certain medication for a patient with asthma and you would like to know if this medication is successful or not, you will send your patient to do spirometry before taking the medication and after taking the medication, and compare the result between the two states. Other value for the spirometry is to diagnose the vocal cord dysfunction. Spirograms. Spirometry generates spirograms. As we took before in the lab for electrocardiography, we called the process electrocardiography, and the recording on the piece of paper, we called that paper electrocardiogram. Here, the process is called spirometry, and the report which appears on the paper, we call it the spirogram. The spirogram simply contains tables of the values and the graphs. The graphs show the volume and the flow of air coming in and out of the lung from one inhalation and one exhalation. Spirograms are either 1. A volume versus time curve showing volumes in liters along the y-axis and time in seconds along the x-axis. And the other form of the spirograms is a graph that show flow volume loop, which graphically depicts the rate of airflow on the y-axis and the total volume inspired or expired on the x-axis. Is pulmonary function test an easy test? The answer is yes and no. It is yes, an easy test if the patient is cooperative, and no if the patient is not cooperative, or if the patient is a young child and this test is not suitable for children less than 6 years old, and of course it cannot be performed on unconscious or heavily sedated patients. Forced vital capacity can only be underestimated and never overestimated. If the patient is cooperative, the result will be successful and the value should be close to normal or less than normal if he is in a critical case for a certain pulmonary disease. But it will never ever be more than normal. Keep this in your mind for the future. What you should know also in medicine, that many intermittent or mild asthmatics have normal spirometry between acute attacks or acute exacerbations. Many asthmatics, between the attacks, if they come to the hospital and if the test will be performed for them, the value will be within normal. Now, let's be familiar with the graphs in the spirogram. The graph in the top is the volume time curve. This kind of a graph will give us the values for the volumes and for the capacities. Some spirograms, they replace this graph by a table, and within that table it gives you the values of the vital capacity and the tidal volume, etc., etc. The lower graph is the flow volume loop. This is a very important type of a graphing because simply it gives us the flow. The upper graph can just give us the normal values and it will not give us any idea about the flow. But without knowing the flow, we cannot differentiate between restrictive and obstructive lung diseases, and other diseases. So clinically speaking, most of the spirograms, they rely on the flow volume loop in assessing diseases. So you students should be so familiar with the flow volume loop, and you should understand every detail of this loop, and you should know every parameter and how it can be evaluated clinically. Now, how do we perform the test, and how do we obtain the flow volume loop? The test starts at point 1, as you can see in the graph. We ask the patient to take as much air as he can to fill his lung, means we are going to reach to the total lung capacity. Once his lung is fully filled, we will start the test, and we will ask the patient to exhale the whole air he can expel, and as fast as possible. And the patient will start the exhalation as fast as he can, and this will be shown in the upper part of the curve, because the upper part represents the expiration period. And as you can see, first the air will flow out very fast from the mouth of the patient. It will reach to the peak expiratory flow, or what is called the maximal expiratory flow, and then the flow will be much less in magnitude anyway, and the expiration will end at point 2. And as you know from the theoretical lecture, the end of his maximal expiration means the only air volume remains in the lung will be the residual volume. And at point 2, the patient will take now the maximal and fastest inspiration that he can take till he fills his lung to the maximal, and that will show the lower part of the curve, which represents the inspiration, and the patient will go back to the total lung capacity. By this, the loop will be closed. What you need to observe now, two very important points. The first point, that the upper part of the curve has a peak which is pointed, that we call the peak expiratory flow, or the maximal expiratory flow, while the maximal value in the lower part of the curve is not pointed. There is no peak like in the upper part of the curve. It is much wider. So the maximal or the peak inspiratory flow is not pointed. The reason for that is very simple, and I explain that for you in the lectures. When we do a forceful expiration, the lung will compress on the bronchioles and the resistance will increase. So the more force we use for the expiration, the greater will be the resistance for the outflow of the air from the lung. That's why the peak will be pointed in expiration. The reverse will happen during inspiration. Inspiration will be easy, because when we expand the lung, the diameter of the bronchioles will increase and the resistance will be lowered. So the area under the curve is wider during inspiration. I told this point for you in the lectures, and as you can see here, there is no pointed peak in the inspiration. Please note that scientists divide the expiration and the inspiration into 4 segments, which is the first part is 25% of the interval or 25% of the forced expiratory flow, and 50% of the forced expiratory flow, and 75% of the forced expiratory flow, and of course till we reach to the end of the expiration. What is important as a parameter is to measure the peak expiratory flow or the maximal expiratory flow is the same, and some physiological parameters are considered more important than the peak expiratory flow. It's the flow, the mean of the flow between the value of 25 and the value of 75, meaning we take how much is the flow when 25% of the expiration has been performed, and what will be the flow when 75% of the expiration is performed, and we take the mean value for these two values. Some physiologists, some books of physiology consider the mean is more important than the peak expiratory flow in assessing the degree of obstruction in diseases. Some physiology textbook says that a small airway obstruction is better diagnosed with the mean between the value of 25% and 70%, while big or larger bronchial obstruction are better diagnosed with the peak expiratory flow or the maximal expiratory flow. This is the normal spirometry chart. The upper curve represents the normal flow volume loop we just speak about in the previous slide. The lower curve is the representation of part of the volume time curve for just few seconds of forced expiration to obtain the expired volume in the first second. This volume will be used to measure the FEV1 when we divide it by the forced vital capacity to obtain the ratio. We said before that this parameter is very important for the diagnosis of obstructive lung diseases. That's what we see in obstructive lung disease. Please look at the upper figure. The upper figure for the flow volume loop in obstructive lung disease, the limb of the expiration is concave, as where I point the arrow, and because of this concave, definitely the forced expiratory flow between 25% and 75% of the flow, the mean will be much low. And in obstructive lung disease, usually the forced vital capacity remains normal. That's what happens in asthmatics. The lower curve shows you that the peak flow compared with a normal person, the FEV1 will be much less than normal, and the patient need to take more time to reach to the value what should be normal. In the normal person, this value will be reached in the first second, but in a patient with asthma, for example, he needs about 3 or more seconds to reach to the same value a normal person can reach for the expiration within the first second. This is the situation in restrictive lung disease. The changes are not in the shape of the flow volume loop, but in the volumes. Please note where I put the arrows. In restrictive lung disease, the total lung capacity is dramatically decreased, but the slope of the expiration curve, or the expiration part, is normal. Also, for the recording of the flow in the first second, the patient can reach 80% of his expiration within the first second, as in a normal person. Of course, the normal person gets more volume in the first second, but the percentage is the same, 80% for the normal person, and also about 80% of the air can get out from the lung within the first second in restrictive lung disease. So the change is in the volumes, not in the parameter we used to see in the obstructive lung disease. This slide shows you the flow volume loops of different respiratory diseases collected in one slide. Graph A represents the normal flow volume loop, as we discussed before. Diagram B represents an obstructive case of pulmonary disease. Please note that in some obstructive diseases, such as in asthma, the residual volume will not be affected. But in other obstructive lung disease, such as in chronic bronchitis, the residual volume can increase. Diagram C represents restrictive lung disease, and in this disease, all lung volumes will be reduced. There will be a reduction in the residual volume, and there is a reduction in the total lung capacity. Diagram D represents fixed obstruction of the upper airways. What we mean by that, in some diseases such as goiter, and you will know this terminology later in the endocrinology module, goiter is enlargement of the thyroid gland in the neck. And if the enlargement is great, it can make compression and pressure on the larynx and will obstruct the flow for air, whether in or out. So there is increase in the resistance for the inspiration and increase in the resistance for the flow in the inspiration. So the curve will cut from the upper part and the lower part, and that's what will show that's what you can see here in diagram D. In diagram E, there is variable extrathoracic obstruction. What we mean by extrathoracic obstruction means obstruction outside the lung and the thorax. And in this case, an example of this case is the paralysis of the vocal cord. When there is weakness and paralysis of the vocal cord, when we are going to do inspiration, once we inspire air, the vocal cord will be sucked in, and almost they will close and make obstruction for the inlet of the air. So the obstruction will be during inspiration. While if we'll try to do expiration, on the contrary, the wind of the air will push the vocal cord up and open the way further, so there will be no obstruction during expiration. So the cut in the curve will be in the inspiratory part. And finally, diagram D shows you variable intrathoracic obstruction, like in tracheomalacia. This is a congenital disease when the cartilage in the bronchioles are weak and they cannot keep the bronchioles wide open all the time. So during inspiration there will be no problem because the lung will be increase in size, and it will open all bronchioles, while during expiration, because of the weak cartilage, the bronchioles will be obstructed almost, and there will be difficulty in getting the air out. So the cut in the curve will be during expiration. As you can see, that spirometry is essential to diagnose many diseases. This slide describes the cases presented in the previous slide. Please read it carefully to understand each figure we discussed before. What I would like you to know from this slide is that a proper spirogram that should contain tables that show absolute lung volumes and the calculated parameters, not just figures, because figures alone cannot give you the proper idea about the diagnosis. In conclusion, this slide shows you how we apply in medicine the parameter of the pulmonary function test. You can see here many parameters like the FEV1, the forced expiratory volume in the first second, the FVC, the forced vital capacity, and the ratio between them, that's to say the forced expiratory volume in the first second divided by the forced vital capacity. The bronchodilator response means when we give beta 2 receptor stimulator like the one you used in asthma, like Ventolin, which is salbutamol. We use it before we use the test, we perform the pulmonary function test and spirometry before giving the bronchodilator and after giving the bronchodilator. Also, you can see the MEF, which is the maximal expiratory flow, the RV, which is the residual volume, and the last parameter you see here is the parameter for the diffusion capacity for the carbon monoxide. I give you the theoretical part about this parameter in lecture 6. Please refer to that lecture to understand it. And you can see here how can we differentiate between different diseases relying on these parameters. For example, in asthma, the first three parameters could be normal, or as in a crisis or in severe bronchospasm, all the first three parameters will be reduced. Does the patient respond to a bronchodilator? Yes, in asthma there is a response. And you can see here that the situation is completely different if we compare it with other diseases. The asthma is an obstructive lung disease, and a small airway disease and emphysema, they are also obstructive lung disease, but you can see here that the parameters are not the same. And by analyzing these parameters, understanding how everything is going on, we can differentiate in medicine between these diseases relying on the parameters of the pulmonary function test. I hope this practical session is clear now for you. Definitely you will understand it better in the future when you practice medicine, but you need to know the basis and you understand what's the clinical application of the pulmonary function test. And if you have any question, as usual, please don't hesitate to ask me, and good luck.